Our next speaker is Clem McPherson. Clem is a visiting professor, which I've discovered we would call here a professor emeritus at the public health and epidemiology at Oxford University, and he's a fellow of New College in the Nuffield Department of Obstetrics and Gynecology. He chairs the UK Health Forum, which is concerned with preventing premature mortality from non-communicable diseases in the UK. And he also chairs the NICE program development group for preventing cardiovascular disease in populations. His research is in epidemiological methods and women's health, and he is co-author of the Foresight Report on tackling obesities in 2007. For him, he traveled here yesterday to be with us. It's 10 o'clock at night, and we welcome him.
Thank you, Andy. Thank you also for inviting me. It's a fantastic meeting. I'm enjoying every minute of it, learning a hell of a lot. And I'm very glad to be here. I've never seen Niagara Falls before this morning, so that's a news for me. I want to talk about issues to do with running randomized controls in gynecology. Now, there are many significant influences in my life, one of which, of course, is Dave Sackett, but there are many others, and the other is Archie Cochrane, who wrote in his book, Effectiveness and Efficiency, that he was going to give the wooden spoon to gynecology and obstetrics for doing less experimentation than any other clinical specialty. And that's where I work, and I've been doing I've been doing some observational studies in gynecology over the last 20 years, worrying essentially about the utility or otherwise of the various treatments that women have to undergo for their heavy periods or their fibroids or whatever else. And these observational studies have yielded quite a lot of information about the relative role of hysterectomy versus endometrial ablation or embolization for various treatments of an observational kind. It came, though, gradually in the middle 20s, noughties, that we ought to be doing more randomized trials in gynecology. And I wanted to do a randomized trial because I've done a lot of work on embolization, and I've done a lot of work on myomectomy observationally. And it came obvious that one needed to do a straight comparison of myomectomy with embolization. Why did it become obvious? Because it was clear that women increasingly were having their babies later. Uterine fibroids are extremely common. Maybe 70% of women aged 50 have uterine fibroids, only half of which are symptomatic. And what they were being offered largely were hysterectomy. And clearly, women who are having their babies later might not be too keen on having a hysterectomy when they were 38 or 40, when they had not as many babies as they felt they might ultimately need. In other words, they wanted to retain their opportunity for being pregnant. So the question I want to address now, which is kind of orthogonal to many of the methodological issues we've been discussing, is how the hell do you answer this question from a group of people who clearly aren't too keen on understanding what their treatments do? And that's not a pejorative comment. It is true, I think. And as I'll come to explain why I think it's true, is it possible to, it's a subtext, is it possible to know which method of treating uterine fibroids is best for women not wanting a hysterectomy? It won't be one answer. Different women will want different things, but we need to know the parameters associated with it. And I think that there is probably some evidence that suggests there's a therapeutic transition going on. I'll come to explain this in a minute. People are getting less and less enamored. In my country, I don't know about yours, I'll come to yours in a minute, but in my country, people are getting less and less enamored with hysterectomy as a treatment for benign conditions, basically, because they regard it as too radical and for closing too many options, and they would like a less radical treatment. And there's a shortage of less radical treatments for women who suffer from uterine fibroids, basically, and that needs to be answered. And I'm going to come to the evidence for this in a tick. What used to happen, broadly speaking, in my youth was that women had babies, they got their fibroids, and they had the hysterectomy, and all was done and dusted. No longer so easy to do that because women are staying in work longer, and they're having babies longer, and also they don't want, some in my country anyway, so they don't want hysterectomy as readily as it has been in the past provided. Now this is age-specific rates of hysterectomy in about 12 different countries, all members of the OECD, and you don't need to discern too much of this graph, except to note that USA and Canada are right up there somewhere. Ooh, That wasn't intended. That's the one. That's USA and Canada, this one here. That's USA and that's Canada, and here's UK and Scotland, basically. And you can see that age 30 to 34, there's a massive increase, or 40s, massive excess number of hysterectomies amongst young women in North America compared with the UK. And that is not all for fibroids. In the UK, hysterectomies, 19% of hysterectomies are basically for fibroids. I have no idea what proportion of the American or Canadian hysterectomies are fibroids, but we can presumably find out. But there are issues, cultural issues, demographic issues associated with this procedure. There is, though, some evidence to suggest that the rates of hysterectomy are converging. They haven't converged, but they are, at least in the middle 20s, and in 2004, there was some evidence to suggest they were converging. So there is some notion that hysterectomy is becoming more uniformly applied across the various countries. Now, I started agitating to do this randomized trial sometime in about 2007, 2008. And I met in a nice committee I was on heavy menstrual bleeding, this wonderful woman called Bridget York, who runs a fibroid information center for women who've got uterine fibroids. And she wrote to me essentially this kind of evidence, which I think is quite persuasive. Women who've got fibroids want to avoid hysterectomy on the whole because they think, to preserve their fertility. That's fair enough. And they conducted a poll of over 7,000 women, and 81% of women wanted an alternative to hysterectomy for fibroids. It's quite a evidence from the consumer to suggest that hysterectomy is not the answer for them with fibroids. And so 82% of women had hysterectomy recommended to doctors, but despite the fact that they still might want to have children, and so on. So clearly, from the consumer's point of view, there was some need to answer this question: which operation is best amongst people who want to have their fibroids treated because they're symptomatic and also maybe affecting their fertility? We don't know that, but maybe affecting their fertility, and there are several operations that we could think of. And of course, just applying the understood demography, people are having their babies later, and they are going to have increasing numbers of babies as we go on through the years, age 35 to 39 and age 40 to 44, at least in my country. I'm sure it's the same in your country, but we can check that, obviously. So a large number of women in their late 30s are still wanting to have babies and need to know the answer. So we do have there we have two operations. One is myomectomy, which is surgical removal of the fibroids, and one is embolization, where you block off the arteries feeding the fibroids, and the fibroids atrophy and fall out. Very different interventions, extremely different. One short stay, one long stay, one surgical, one non-surgical, one day case, one not day case, and so on. And strong consumer preferences. Some people don't like the idea of embolization because it's pushing out the fibroid is like having a baby. Other people don't like myomectomy because it's heavy surgical stuff with a lot of bleeding, and they don't like that either. So there are lots of strong patient preferences, but patients need to know the answer, and where are they going to get the evidence from an RCT? So I suggested we did an RCT, and what I'm going to describe to you is basically I think a massive change of heart amongst a particular specialty associated with answering this question. And what do we do about it? We know, one thing we do know, that myomectomy is not itself a panacea. It gives rise to adhesions, which again affect fertility and can give rise to depleted ovarian function and fertility rates. But the professions specialists in 2009 were quite clear about what should happen. The Royal College of Interventional Radiologists and the Royal College of Gynecologists got together and they wrote clinical recommendations on the use of uterine artery embolization in the management of fibroids. And what they said was unequivocal. Clearly, more evidence is needed to establish the role of UAE, that's embolization, in patients wishing to maintain their fertility. And this will require a large ECT with a long-term assessment. In the meantime, UAE should probably be reserved for patients wishing to maintain fertility who cannot, e.g. because they've got multiple fibroids, or will not undergo myomectomy. So it's a kind of second-line treatment for people who might want to have babies. And what they're saying here is that we want a large randomized trial in which we can measure the difference in fertility associated with myomectomy or embolization. Well, if you do the sums, such a trial would need to be several thousand big in order to detect an effect on fertility. And in particular, if you wanted to detect an effect on obstetric outcome associated with that fertility, a difference between the two. And we knew that we wouldn't get funding for such a trial. Why? Because this is a benign condition, okay, it's very common, but there are other more exacting things that research funders should be engaged in. We also knew that gynecologists probably wouldn't play ball for such a big trial. So we managed to get enough enthusiasm for a trial of quality of life, actually, or actually reoperation rates. So there's international recognition that data are needed from RCTs. Lots of suggestions that suggest that we need to know more. There have been some comparisons of myomectomy in the literature, basically with UIE. There's only one randomized trial, small randomized trial, done in the Czech Republic. It's Mara et al. And it's basically 40 people, 50 people randomly allocated to myomectomy and 50 people randomly allocated to embolization. And fertility is one of the outcomes. Far, far too small to know what's going on. So that's the only randomized evidence. The evidence is otherwise observational. And so Mara says it's difficult to compare because they've got small numbers, and there's some evidence, very second-rate evidence, that suggests that embolization is not so good for fertility, but it's ridiculous. It's much too small. So we proposed this trial. We put in an application to the HTA in 2009. Me, a couple of gynecologists who are keen to do this study, a couple of radiologists who are keen to do this study, and the Birmingham Clinical Trials Unit very keen to do this study. And the HTA, after a hell of a lot of huffing and puffing, it must be said, gave us £2 million to do a randomized trial of this particular process between various centres in the UK and about 600 patients. And the objectives are written out there. They're the obvious ones you'd expect to see to not understand the difference, because there are a lot of things going on here which women need to know the answers to before they can make up their minds about which procedure to choose. So we proposed 600 patients and obtained the enthusiastic support of 38 gynecologists around the UK, promising around 1,400 eligible patients per year. It was going to be a doddle. We're going to get these people in, easily randomized, and moving on to get the answers. So we've now got centres throughout the UK, and we are trying to move ahead. The first thing that happened was ethics and R&D approval in each of the centres took forever. Took a year and a half, took 2 years. As we know, these trials just get stuck in the administration for a very, very long time. And when we came out of all that and said, okay, now in this centre we can randomise patients, and in that centre we can randomise patients because we've got ethical approval and R&D approval, we went back to the gynecologists and the radiologists and said, okay, we're ready to go. And they said, ready to go to do what? And we said, well, the trial. Well, the trial. I'd forgotten about that. Yes, of course. Let's have a go. And this is what has happened since. You can see this graph. We thought we would, by about August 2013, we would have about 600 patients by recruiting from big centres and small centres across the country. We all know this is a phenomenon that happens in randomised trials, but this is ridiculous. We got 67 patients after speaking to the gynecologists, speaking to the radiologists, speaking to everybody else, and the HTA said, we're going to have to pull the funding on this one. It's not doing the job. And we said, oh, you're probably right, but then perhaps we can try a bit harder. And so we tried a bit harder, and we pushed our objectives down to want to have only 220 patients. And I'm not going to go into the reasons for that, but there were valid reasons for doing that, which kept the power. It's just that the trials on which we based the power had inadvertently misanalyzed the data, and we had a wrong estimate from those data of the variance of the quality of life measure. So there we are at this moment, 2009-13, with 106 patients. Recruiting, the HTA have said we've got to have 10 a month. If we don't have 10 a month, they will close the trial down, and we will have no answer to this question. And it's been a nightmare. So my question really is this. It is clear that women need to know the answer to this question. A lot of women need to know the answer to this question. In my country, and I'm sure in your country, and in the US, women need to know the answer to this question. They need to know how to make a decision about their treatment for their uterine fibroids, which are very common with respect to their current fertility, their current quality of life, with respect to their operation rates, with respect to the acceptance of the operation. We need to know the answers to these questions, and I'm sure that if the HTA, which they might well do tomorrow, close the trial down, we'll have 109 patients or whatever it is, and that'll be useless pretty much, and we'll never know the answer, and the women will never know the answer, and the women will not be in a position to make an informed choice about which of these radically different treatments to opt for based on evidence, because there will be no evidence. Now, the observational data is quite clear. This is done by some interventional radiologists, and they've looked at all the evidence on fertility outcome associated with UAE, and they have concluded quite clearly low-level evidence from these studies suggests that pregnancy rates following UAE are comparable to the age-adjusted rates in the general population, which is absolutely fine. And you tell the gynecologist this is the data, they say we don't want to know about that, it's observational. We need randomized trials. Oh, you need randomized trials. Well then, you need to randomize some patients. Well, no, we can't do that because UAE is dangerous. It's not dangerous. It says here that it's not dangerous. This is observational data. This is a catch-22. Please help me get out of it. Thank you.